Hello, and thank you for joining today's Vascular Access Infection Reduction Strategies from the ED to the ICU webinar. Today we will hear Dr. Jacob Keeperman from Reno, Nevada, discuss infection reduction strategies, including how the choice of vascular access device and kit configuration impacts incidence of bloodstream infections. At the end, we will also have a short question and answer section. Before we begin, let's review a few housekeeping items. First, at the bottom of your screen are multiple tools you can use, including thumbs up, claps, and other reactions to react to the content being presented throughout the webinar. Second, all the windows you see on your screen are resizable and movable, so you're welcome to move them around to get the most out of your monitor space. If you have any questions during the webinar, you can submit them through the Ask a Question tool. We will try to answer these questions during the webinar, but if a fuller answer is needed or we run out of time, we will be answered later via email. Please know that we do capture all questions. We encourage you to download any resources or links that you may find helpful in the related content window as well. A recording of the webinar will be available via the On24 webinar platform, on YouTube, via the Teleflex Vascular Access LinkedIn page, and the Teleflex Academy website. Also note this webinar is not for continuing education credit. Now I'd like to introduce Dr. Jacob Keeperman. Dr. Keeperman is a paid consultant of Teleflex Incorporated, and we appreciate his partnership and commitment to bettering patient outcomes. Dr. Keeperman is an executive medical director, associate professor of anesthesiology and emergency medicine, intensivist, and EMS medical director. One fact about Dr. Keeperman is that he himself has been a patient and suffered a complication from a line placement and will speak from personal experience about the importance of preventing central line bloodstream associated infection. With that, I will turn the webinar over to Dr. Keeperman.
Good afternoon. Thank you, Michael, and thank you to the Teleflex team. Thank you all for joining us today. I'm going to talk a little bit about central line placement, vascular access, and CLABSI and CRSBI rates. We know that we need to do our best to decrease, if not eliminate, CLABSIs. There are over 30,000 CLABSIs in ICU patients in the USA per year. And it has an associated mortality of up to 25%. In addition to those patient-centric issues, for health systems, the cost per infection can range from almost $18,000 to upwards of $100,000. So what do we need to think about in terms of decreasing CLABSIs? Today, we're going to go through several areas that we need to consider so that we can keep our patients as safe as possible. We need to think about where to insert a line, what to insert, when to insert, how to insert, and consider the different patient settings. Because ultimately, we want to lead to fewer complications and better outcomes. So from a clinical perspective, it's absolutely essential that we only do patients that are necessary. And we need to not say, well, what if they need this later, or what if they need that, but let's think about what the patient needs and make it totally patient-centric. We want to make sure that the first insertion is done correctly. If we can put in the correct line the first time, and we put it in the right spot, and we do it well, then we are going to improve patient outcomes. And we can do this by using all-in-one kits, like the Aero ErgoPack Complete, which you can use for central lines, like triple lumen, MAC catheters, multi-access catheters, and PSIs, percutaneous sheath introducers. So insertion planning, how do we plan ahead? So you have to think about your insertion site. The typical insertion sites used are the internal jugular, subclavian, and the femoral veins. We want to do what we can to control the catheter's rate of microbial colonization and see how antiseptic catheters can help us with that. So based on a 2005 study by Rupp and colleagues, in which they compared protected antiseptic catheters like the AeroGuard Blue Plus to unprotected catheters, we saw that in the femoral location, about 30% of the control catheters were microbially colonized versus 4.5% for the AeroGuard Blue Plus. At the IJ location, there was 19% colonization in the control group versus 11% in the AeroGuard Blue Cross. And then for the subclavian sites, 5% colonization in the control group and 4% colonization in the AeroGuard Blue Plus. So while we cannot directly correlate these to infection, we know that if there is colonization on the outside or the inside of the catheter, it's going to increase the risk of developing a bacterial infection. So what kind of catheter should we insert? So there are CVCs, central venous catheters, which we refer to as our triple lumen catheter, single lumen, double lumen, there's quad lumens. The MAC catheter, the multi-access lumen catheter, which can be great for resuscitation. The PSI, or percutaneous sheath introducer, also commonly called a Cordis by people, although Cordis is a trade name. And then the acute hemodialysis catheter. So these are all really important. But we need to remember these aren't the only vascular access devices that we can think about. We need to think about what's right for the patient in the setting they're in at that time. So if somebody has adequate peripheral IVs, you can resuscitate them with that. If somebody has an IO, use that or put that in if you can't follow appropriate sterile technique. There are RIC catheters, rapid infusion catheters. There's a whole plethora of options that you want to make sure that you consider to make sure that you're doing the best for your patient at the time. So when to insert? When we are resuscitating somebody, we need to think about what to do, when to do it, and how to do it. So do you do airway or do you do a line first? Well, it depends. If you expect somebody to potentially have a peri-intubation arrest, you obviously need to ensure that you have adequate vascular access. And it doesn't mean that you will take the time to appropriately place a central venous catheter. Remember, you need to place a central venous catheter following very strict sterile precautions. You want to have plenty of room to have your ultrasound guidance. You need to have an assistant in the room. And we know that during a resuscitation, that is not always available. So maybe you place an IO, you intubate the patient, you can manage any immediate peri-resuscitation and peri-intubation hemodynamic instability. And then once you get the patient to the ICU or you get them to a somewhat more stabilized setting, you can place the CVC or the MAC or the PSI. Should you wait until you get to the ICU or do it while you're still on the floor? Well, again, let's remember what supplies are available to me on the floor. Is that staff used to somebody placing a central line? What is going to be the safest thing for the patient? The reality is I can put in IO in 99.9% of patients within 10 seconds, extremely easily. I can give any emergency medication I need on the floor, and then I can transport them to the ICU, again, where I can follow the necessary bundle for central line insertion so I can prevent collapses? And when is it indicated? So just because somebody might in the future need pressors doesn't mean a central line is indicated. Just because they might need a lot of blood draws doesn't mean central lines are necessary. So let's go through several steps. One, how to insert. Patient positioning. It's important that you take the extra time to position the patient appropriately. Most of the procedures that are performed in the out-of-hospital setting, ED, OR, ICU, are not that terribly difficult. Yes, we've gone through a ton of training. We do them a lot, so we can do them. But what makes them much easier is if we spend the appropriate time positioning the patient, making sure that lines and tubes aren't in the way, making sure that we're moving the telemetry cords, monitoring wires, making sure we have our equipment readily accessible, making sure that your ultrasound machine is in front of you where you can see it. Make sure you have support staff available. If you drop something and you need someone to get something, if the patient might be moving a little bit and you need an assistant to help hold them down, if you need to give them a little extra sedation or whatever the case may be, it's essential that you have the appropriate personnel to assist you. Prep your equipment. We all know that we don't use every piece of equipment that comes in every central line kit, A-line kit, or anything like that. So get rid of the things that you don't need. Get rid of your trash as you go along. Make sure that you are appropriately handling your sharps and other devices that can injure you or someone else. The Teleflex Aero Ergo packs are designed in a fantastic manner that it has what you need and you can get to it in the order that you need it for inserting a central line. I take the time at the beginning to make sure that I get the appropriate caps on the central line, that I am flushing all of my tubing, that I'm labeling my lidocaine syringe and giving my local anesthetic. It's so important that we take the time to do it correctly. And next, use ultrasound guidance. The Institute of Medicine many years ago came out with very clear guidelines that we use ultrasound guidance for placement of central lines. Sure, it's not always easy to use ultrasound for subclavian line guidance, although there are multiple published studies demonstrating how to do it. But the reality is, most cases, most times, an ultrasound machine is available. It will improve the speed of the procedure, it will decrease complications, and it will ultimately lead to better patient outcomes. So we're going to talk a little bit about the patient journey, from pre-hospital to ED, to OR, to ICU, to the floor, into discharge, and talk about some of the different components of central venous access during those different times. So pre-hospital, what's available? Where to insert, what to insert, and how to insert. So typically in the pre-hospital setting, peripheral IVs are used. Does every patient need one? The reality is no. But often EMS feels like they need to do something and they place a peripheral IV in someone. And if they have placed a peripheral IV and it works, great, use it. IO is another fantastic option for the pre-hospital setting. It's quick, it's easy, and it's incredibly effective. And really the ultimate location to place that is in the proximal humerus. This allows rapid infusion and allows easy resuscitation. In the past, many people were placing IOs in the proximal tibia, but more and more studies and more experience has showed us that proximal humerus is the location to place an IO. Very few, if any, pre-hospital or out-of-hospital services are placing central lines. And frankly, there is no good way in the out-of-hospital setting to do that in a sterile and clean fashion. How about the emergency department? Again, peripheral IVs and IOs have their place and are great. And if somebody has one and it's working, use it. If you need to rapidly resuscitate somebody, you have a patient with a GI bleed, a RIC or a rapid infusion catheter is also an incredible tool. Those are designed to be placed converting a peripheral IV using the Seldinger technique to a larger bore, very large bore peripheral IV. And they are great for resuscitation. Remember, we can much quicker get flow through something that is short and fat than something that's long and skinny. If somebody in the ED needs a central venous catheter, fine, give them one. Think about what that patient not only needs right now in your ED, but what they're going to need when they go to the operating room or the ICU. Are they only going to need one lumen? Well, probably not. If they are that sick, they're likely going to end up on multiple medications that are likely not compatible. So you want to think about giving them multi-lumens. And I would recommend placing at least a triple lumen catheter, if not a quad lumen. That's going to allow, with that single insertion, it to be used throughout the patient's stay. What about placing PICC lines in the emergency department? I say no. PICC lines are never a resuscitation line. There's no such thing as needing a stat PICC line. It's long and skinny. It does not allow for adequate resuscitation, and it is not in the patient's best interest. So place the central line if needed. Well, where are you going to place it? Are you going to place it in the internal jugular, the subclavian, or the femoral vein? Well, we have to consider the pluses and minuses to each location. The internal jugular vein is a great location. It's easy to see with ultrasound. You can also find it using landmarks. It's easily compressible. Remember, whenever you are thinking about placing a central line, there are risks. There's risks of bleeding. There's risks of arterial puncture. There's potential risks of pneumothoraces. There's risks of thrombotic disease, and of course, the risks of infection. So the internal jugular site overall for those things is pretty good. Obviously, that's going to have a risk of pneumothorax where a femoral site will not. But make sure that you're weighing this. Now, in the emergency department, often you have a patient wearing a cervical collar, so the internal jugular site becomes problematic. There's often several people at the head of the bed between nursing staff, respiratory therapy staff, other providers, so it may be challenging to access that location. So you might want to consider other places. So next, let's talk about the subclavian location. The subclavian certainly can be accessed using ultrasound guidance, but I would say most people in practice do not. So that's one piece of equipment that might not need to be in the way. You can also place a subclavian when somebody has a cervical collar on. In a trauma patient, for example, that already has a pneumothorax, a subclavian on the same side of that pneumothorax is probably a good idea, because the biggest complication being pneumothorax, you already have one, so you're not causing a new complication, and hopefully you will have already treated the pneumothorax that the patient has, and so if you do happen to go into the pleural space again, you will already have treated that potential complication. What about the femoral site? So the femoral site used to be the quote, go to dirty central line site of the ED, a line would be thrown in during a code, not following sterile technique, not doing a full barrier drape of the patient, not having adequate equipment, not with everybody having hair coverings and masks on in the room. That's just not acceptable in today's day and age when we have other vascular access options. So if that's the position you find yourself in, where you cannot appropriately perform a central line insertion following appropriate sterile technique with full barriers, following all of the central line insertion checklists, then don't put in the central line. Place an IO. You can resuscitate through it. It's extremely quick and extremely effective. And only when you can follow the proper technique should you place the central line. When I am in the ICU and I receive somebody who has a central line that was placed in the femoral location, I think about why. So maybe it's because the patient is incredibly anticoagulated. Maybe the patient received TPA for a stroke, and then they became hemodynamically unstable, and so the central line needed to be placed in the femoral location. And that's absolutely acceptable. Just do it in a sterile and clean fashion. When I'm in the ICU, I will often avoid placing a femoral line, if I can, because I want mobility. I want the patient to get up and moving, and it is hard for a patient to ambulate when they have femoral vascular access. How about in the OR? The biggest thing I see in the OR is patients come out with a central line, but it's a single lumen or a double lumen. And as I talked about previously, think about what the patient is going to need, not just in front of you, but at the next phase of their care. If you are operating on somebody and they are so sick that they need a central line, they're probably going to need that line when they go to the ICU. So I would really recommend that you put in at least a triple lumen so that there's adequate access for in the intensive care unit. When we think about compatibility of drugs and what can go through a central line, in the ICU, we often have people on a dextrose-containing fluid. We often have people on vasopressors. There's often an antiarrhythmic. There's often some anticoagulation and antimicrobials. And the reality is those are not all compatible and can't all be given through the same lumens. Yet many of those medications need to be given continuously or on a fairly frequent basis. So having adequate access is key. Because what we don't want to do is receive the patient in the ICU and have to change the central line that was placed in the OR to something more. Because that's now introducing an exceptional amount of increased risk to the patient. Remember, you can also use an IO in the OR. They're incredibly effective for resuscitation. So how about in the ICU? So I use all sorts of vascular access devices in the ICU. I still use peripheral IVs. I still use rapid infusing catheters. I still use IOs. But obviously I place also a lot of central venous catheters. I place triple lumens. I place MAC catheters. I place acute hemodialysis catheters. Those are all incredibly important for the patients. And we've talked about the different locations of placing these catheters, and I think about them often. And when I'm thinking about things such as the internal jugular, I think about, is this patient headed down the path towards dialysis? And do I want to save the right internal jugular in case they need long-term dialysis access? Is this somebody who might need a transvenous pacemaker or a pulmonary artery catheter? In which case, I will often avoid, again, the right IJ and go to the left IJ or go to the right subclavian so that the more peripheral locations that have a little bit more direct path to the right atrium can be saved for the temporary transvenous pacemaker, for the PA catheter. I often will avoid the left subclavian, again, thinking, is this patient going to need long-term dialysis access? But maybe what I do most importantly in the ICU to decrease the risk of infection is I say this patient doesn't need a central line. I say they're on a very small dose of norepinephrine, and I expect that that is an effect of the anesthetic that they had received or of the sedation that I have them on from the ventilator that's going to rapidly come down. And they can safely have their vasopressor administered through a peripheral IV. And maybe if that vasopressor dose doesn't decrease as I was hoping, or other things happen, then I can place the central line when I know the patient really needs it. I also remove catheters, and I remove them as soon as possible. Best practice is to consider the need for a catheter at least every single day, saying, do they need it? Why do they need it? What can we do instead? Get out catheters that are not needed. It's incredibly important if somebody does have a catheter that the site is cared for appropriately, that the dressings are changed, that a soiled dressing is changed immediately, that there is some protective barrier like a biopatch between the skin and the dressing, that people are appropriately washing their hands and changing dressings using appropriate aseptic technique. These are all essential, again, to preventing collapses and improving our patients' outcomes. How about on the floor? Again, think about peripheral IVs. IOs can be used. Midline catheters can be used. Think about getting out a central line if somebody comes. I really dislike sending people out of the ICU with a central line in, because my fear is that it will stay in because there is a convenience to staff where it's easier for blood draws, but they don't really consider the other complications. Get them out as soon as you can. And please, please, please don't reflex to a PICC line for everybody. PICC lines are central lines. They're just peripherally inserted. But they still have infection risk. They have thrombotic risk. And we need to do what we can to protect our patients. In a rapid response, I would say a central line is almost never appropriate. Certainly, if a patient already has one, use it. If somebody has peripheral IVs, use them, use the IO. For any of the clinicians on here that have been called to a rapid response, invariably it's somebody who is decompensating and the floor where this person is, for whatever reason, just lost the IV access just prior to you getting there. Well, the answer, again, is not placing the central line right there on the floor or in the suboptimal location at the CT scanner in X-ray. Do something more short-term, like a peripheral IV or an IO. Resuscitate the patient, get them to the ICU or to wherever you're going to continue on with their stabilization, and place the central line, if needed, following the best technique that you can. At discharge, well, does anybody need to be discharged with a central line? I would say no. If somebody happens to need long-term central access, consider a port. consider a tunneled line, again, if they really need them. Because we have shown that long-term lines, like ports or tunneled central lines, have much fewer complications than short-term lines. Also, if a patient doesn't need it, avoid it. Does every patient or do most patients need to be sent home on IV antibiotics? No. The reality is most of the time we can change them to an enteral formulation or something that doesn't require very frequent infusions, and they can get by with having IV sticks when necessary. So always consider, does the patient really need it? Here are some times when you should see a big red stoplight. They might have difficult access. That is not an indication for a central line. They might need lots of blood draws. Also, not an indication for a central line. Or they might need a vasopressor. Well, they might. They might also not need any of those things. So don't place a central line until somebody really needs it. Sometimes to consider it. Well, they probably need a line in the future. They're in the ICU. Right now, they are not on anything that they need it, but they're going to the OR in a bit for an open heart surgery. Well, in the OR, yeah, they're going to need a central line, and most likely afterwards they are. So that would be a reasonable time to consider placing a central line. If you can do it following the best technique, sterile insertion technique with full barrier draping. You have the right line that is coded, right? That is protected so that you are decreasing the chance of your patient ending up as a statistic with eclampsia. Yes, a patient on multiple vasopressors, they need a central line. A patient where you can't get any other kind of IV access. Yes, they're likely going to need a central line. So place it. But again, place it correctly. And place it correctly the first time. So remember, don't limit to thinking about the patient in the short term. Don't think about them just at this point of time, what they're going to need this minute. If you're already going to do the procedure, a significant amount of the risk is related to performing the procedure. So think about how many lumens they're going to need. Make sure you're using a protected catheter. And ultimately make sure that the appropriate insertion site care is being performed and is going to be performed. Make sure that there's an occlusive, transparent dressing so people can watch the site and see if there are any signs of problems. Think about if it limits the patient's activity. Remember, it's very hard for a patient to ambulate when they have femoral access. Think about how you secure it. Make sure that you're suturing it so that it doesn't fall out or it doesn't migrate, because that's going to increase the risk of bacteria sliding along the catheter. Make sure that you are putting the appropriate barrier there, such as a biopatch. Make sure that you are appropriately cleaning the site, and make sure that your dressing is clean, dry, and intact. Remember, often the only part of a procedure that a patient or their loved one sees is the dressing. So make sure it's clean. Use chlorhexidine to clean off a little bit of the blood that might develop there. Treat your patient how you would want you or your loved one to be treated. The Aero ErgoPack complete system has maximal barriers in it, and it's arranged in an ergonomic top to bottom left to right configuration. It's designed to help minimize contamination risk and provide clear sequential procedure steps for the clinician. It includes things like the nitinol wire, which is kink resistant as compared to stainless steel. It has the Aero glide wheel advancer, which helps more smoothly advance the wire. It has an ultrasound transducer cover in sterile gel. It has pre-filled saline syringes that are sterile, that are already open on the field, so nothing has to be dropped on the field where you are risking contamination. And it has extra ChloraPrep skin prep, which allow you to really clean the site well prior to and after insertion of the central line. The AeroGuard Blue Plus CVCs demonstrated a 2.9 times reduction in CR-BSI compared to unprotected catheters. That's based on a RUP study from 2005. That is really important to know. That study was not able to say that there was less bacterial infections because of the extremely low infection rate. But there were 1.24 confirmed infections due to a central line per 1,000 line days for the unprotected controlled catheter, and 0.4 infections per 1,000 line days for the protected catheter. So clearly there is a trend towards decreased infections. The colonization is what is incredibly impressive. So looking at microbial colonization was incredibly decreased for all insertion sites, internal jugular, subclavian, and femoral sites, using a control catheter versus the AeroGuard Blue Plus. Looking at Laurente's 2015 study, the role of antimicrobial impregnated catheters on catheter-related bloodstream infection prevention, we reduced the risk of a CR-BSI by utilizing antimicrobial impregnated catheters, using full barrier precautions during catheter insertion, and by selecting the appropriate site. The same site isn't appropriate for every patient all the time. You have to use clinical judgment. You have to base it on the patient in front of you. And you need to make the best choice for that patient at the time to minimize all of the risks. Decreasing CLABSIs not only help our patients, keep them healthier, decrease their hospital length of stay, decrease their morbidity or mortality, but it also leads to cost savings. A 2020 study looking at comparison of central line associated bloodstream infections between central venous catheters lined by combined chlorhexidine and sulfur sulfadiazine versus silver ionotrophs alone, before and after retrospective study, showed that you can save a huge amount of money on the order of $48,000 per infection. So if you're talking reducing your CLABSI incidence by 9 in a year, the health system could save almost $500,000. That is huge. And ultimately, with all of us facing the financial constraints that the American healthcare system is under, every dollar that we can save adds up and will lead to us being able to provide a better experience for our staff and for our patients. I want to thank you for joining us today I want to recommend and encourage all of you to check out the Teleflex Academy. It has e-learning modules. We'll have links to hands-on training and webinars, and it will allow you to receive valuable continuing education credits. Looking at all of the Aero catheters and other Teleflex products. In your registration materials and follow-up communication you receive from Teleflex, it will have links to the Teleflex Academy and other resources. In summary, I believe every patient has a right to expect 0 catheter-related infections when treated with any vascular access product. And I hope this talk has helped you learn some tools of how to decrease the rates of catheter-infected bloodstream infections. Thank you so much for your time and attention. And I now look forward to opening this up to questions.
Thank you,
Here's
Dr.
a list
Keeperman.
of Thanks, Michael.
Oh, yeah, here are the references used within today's webinar presentation. I just want to say thank you again. I thought that was super informative. And to your point, we're now going to begin answering questions submitted today through today's presentation. For the audience, as a reminder, you can still submit questions through the questions pane on your screen here. And so, Dr. Keeperman, we have 4 questions so far, and the first one is an interesting one. It comes from the beginning of your presentation. Can you touch on the story about how you were a patient yourself and the experience you had with a vascular-related complication and how you learned as a clinician for that to drive your infection prevention and prevention reduction strategies?
Yeah, thanks. So I will share, and it took me a long time to be able to share this story, but now it's quite therapeutic. So I was an intern training in emergency medicine. It was January of my intern year. I developed acute hypoxic respiratory failure. I ended up getting influenza and MRSA pneumonia. I ended up on a ventilator in the ICU for 10 days. When I woke up, when I self-extubated, and I did, because, you know, we make the worst patients, I had a chest tube in place. And I guess I incorrectly made an assumption that it was due to the high peak pressures that I had on the ventilator. I had been prone for several days. I was on an oscillator for a few days, and they had consented my family for ECMO. I found out many years later when I was a fellow that I had a chest tube because I was given a pneumothorax during a central line insertion attempt. I never had hemodynamic instability. I never was on a vasopressor, and I had incredibly adequate peripheral venous access. So I never needed the central line. And in fact, they were never successful in putting it in. So that made me very aware of thinking about why we are doing each procedure that we're doing. Interestingly, what I did not ever get was an arterial line, and I had 87 ABGs drawn during my 12-day ICU stay. So there certainly would have been an indication for arterial line placement, not so much for central venous catheter placement. And that makes me, to this day, always ask myself, ask my colleagues, why do we really need this catheter? How is it going to benefit the patient? And that's really what we are all here to do, is to benefit our patients.
Thank you for sharing that. What a story. So the second question is your recommendation to use IOs in the ED as a standard practice?
So I think that IOs in the ED are absolutely something that should be considered. If somebody has adequate peripheral IV access, use their peripheral IV. Don't place an IO just to place an IO. However, if for some reason you can't get peripheral IVs, if the peripheral IVs are inadequate, you can only get one, and it's a 20 in their hand, and this patient needs to get a resuscitation. Let's say they have a GI bleed, Let's say they're profoundly hypotensive and they need to be started on a pressor, and you don't trust that peripheral IV. An IO is an excellent option to consider. It's something that can be easily taught to the physicians, mid-level providers, nursing staff for them to insert, and it will ultimately save the patient a lot of angst.
Sounds good. So the next one is, thank you, Dr. Keeperman. Excellent review. Many facilities are trying to avoid collapses by using a peripheral option instead of a CVC, even using multiple PIVs. How do you feel about this clinical strategy in quotations?
So again, if the peripheral IVs are adequate, if the patient is simply getting, for example, they were a STEMI and they are going to get a heparin infusion for a few days, and you have adequate peripheral IV access, use peripheral IVs. That's perfectly adequate. If the patient needs more than peripheral IVs can accommodate, if the peripheral IVs are not working for the patient, they continue to blow, other things, then you need to think about other options. So some things to consider. A midline. Is a midline going to be adequate for that patient? Maybe, maybe not. You have to think about it. And I think we have very frequently reflexed from no peripheral IV or not adequate peripheral IV has to be a central line. And so central line is the answer many times. It's not always the answer. The keys to a central line use are use it when necessary and place it in the appropriate setting. So a setting where you can follow strict, sterile technique. You can do maximum barrier draping. You have the appropriate equipment. You have the appropriate personnel. And that the line is going to get appropriate dressing care. And that then the line is removed as soon as the patient no longer needs it. That is really the biggest takeaway, is follow the insertion bundle and remove it when the patient no longer needs it.
That's great. So the next one is, in your practice, do you recommend placing PICC lines in IR or at the bedside from an infection and resource standpoint?
So that's a great question, and I think it really depends on your facility and how the facility is resourced. I think that the important thing is that people doing any of these procedures need to be not only competent at performing the procedure, but they need to excel at performing the procedure. And the people that do it more often are often going to be the better people equipped to do it. Is it necessary for a patient to go to interventional radiology for a PICC placement? I don't think so. In fact, I think that that probably leads to other challenges. I want to think about all the risks. So what are the risks of a patient leaving the floor? What are the risks of a patient going into a setting where those people don't really know the patient very well? What is the resource utilization of IR? I think often when PICCs are placed in IR, people are also less likely to remove the device when it is no longer needed because they assume it was extremely difficult to place, and so make an assumption that it should stay in for a long time when that is not necessarily the case. Every one of these lines, and I'm talking whether it's a peripheral IV, an IO, a triple lumen, a MAC, anything, needs to be removed as soon as it is no longer needed. That is really the key to me to success for preventing infections. But there is no data that shows that somebody going to IR versus a line being placed at the bedside when people are appropriately trained and following appropriate technique changes.
All right, we have time for one more question, and this is an interesting one. Do you have thoughts on suture versus sutureless securement, and when to, if you're going to use sutureless securement, when would you use it?
So that is a great question. I have worked in many different health systems that have had different securement devices. I'll tell you, every one of them that had these sutureless devices, at one point, they all got rid of it throughout time for a variety of reasons. I think the one most providers, most physicians at least, are not used to placing sutureless devices, and so they get incorrectly placed. I think some also depends on the anatomy. I have very successfully used the sutureless devices for midlines, for PICC lines, or for example, a deep brachial IV for things being placed peripherally without a problem. I have not had as much success placing or with the maintenance of lines in the IJ, subclavian, or the femoral location with the sutureless devices. I think part of that has to do with the movement of those body locations. So on the neck by the IJ, as the patient is moving side to side or as we're turning the patient's head to provide other care, we are pulling at the adhesive on those, and I found suture to be much more reliable. Same thing in the femoral location. The subclavian location, I have not had as much experience with the sutureless devices, as those lines are fairly rarely placed.
Sounds good. And that closes our question section. Any additional questions that we weren't able to get to, we will answer via email, and Dr. Keeperman, you'll be involved with those responses. So again, thank you for attending today's Vascular Access Infection Reduction Strategies from the ED to the ICU webinar. And on behalf of Teleflex, thank you, Dr. Keeperman. You were a fantastic presenter. I thought this was very excellent. I look forward to getting additional questions and answering those. And I hope everyone has a great rest of their day.
Thank you all. Take care.